Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastroenterology trainee in the west of Scotland. Today we're discussing acute liver failure, and I am delighted to welcome Dr. Ken Simpson, a consultant physician in the transplant unit here at the Royal Infirmary of Edinburgh. Welcome, Dr. Simpson.
Afternoon.
And thank you for taking the time to join us today.
You're welcome.
So the term acute liver failure is often used to describe various manifestations of liver dysfunction, and I think that causes some confusion. What do we really mean by acute liver failure?
Okay, so acute liver failure is a very rare condition, and there's still a debate and an uncertainty about what the actual definition of an acute liver failure is. So a long time ago, Trey and Davidson presented their original definition as a patient that developed hepatic encephalopathy within 8 weeks of the onset of symptoms in the absence of pre-existing liver disease. And that's a pretty good definition to kind of start off with. Okay, so usually the patient has hepatic encephalopathy as a clinical manifestation. They've got liver failure, so they've got an elevated bilirubin and a coagulopathy. Some of the patients, though, already have pre-existing liver disease. So an exception to the absence of pre-existing liver disease rule would be patients with Wilson's disease that are known to have cirrhosis. And then you've got patients that maybe have hepatitis C or fatty liver, which is very common. But as long as it's not cirrhotic liver disease, then we usually accept that. But most of the patients will present with a severe liver injury, so they'll have elevated transaminases, maybe a coagulopathy, without the hepatic encephalopathy. And that's much more common condition and often doesn't get referred to the transplant unit.
And acute liver failure is subdivided by the time course, is that right?
It is. So time course between the onset of symptoms and the development of hepatic encephalopathy was in the original Trey and Davidson definition. But that subsequently got subdivided and actually used jaundice. So the onset of jaundice before hepatic encephalopathy. So if it's a week, then that's called hyperacute liver failure. Between a week and a month is acute liver failure. And then subacute is anything between a month and 12 weeks, so 3 months. And that's important because the different causes of acute liver failure appear in different subgroups. Okay, so most common cause of acute liver failure in Scotland is paracetamol overdose. That's a hyperacute liver failure. These patients tend to deteriorate very quickly. They have multiple organ failure. The risks of cerebral edema are high. Whereas the subacute patients, they tend to be the more indeterminate or drug-induced patients. And they tend to look much more like patients with chronic liver disease. And so they deteriorate much more slowly, and the risks of cerebral edema in that group are very low.
How common is acute liver failure?
Well, that's very difficult to define because most acute liver failure cohorts are presented from transplant units, and they have a very different referral base. But in Scotland, it's probably less than 1 per 100,000 per year, probably closer to 0.5 per 100,000 per year. So in the Royal Infirmary nowadays, we're taking 30 to 40 cases a year from a 5 million population.
Now you mentioned paracetamol overdose as being the most common cause. What are the other causes that you see?
So paracetamol overdose is the single most common cause. So about 80% of the cases will be paracetamol overdose. And when you say paracetamol overdose, it kind of brings in an idea that the patient's taken a significant amount of paracetamol as a one-off attempt to kill themselves. But actually nowadays we're seeing much more paracetamol overdose that's in a staggered fashion. So it's people that have often taken cumulatively quite significant amounts of paracetamol but spread over a number of days, and they present in a very different way to the single one-off overdoses. So the single one-off overdoses will usually present because they've taken an overdose, not because they're unwell. They'll present saying that they've taken an overdose. You recognise it as such and treat it as such. The patients that are taking staggered overdoses often don't present until they're very unwell, and so they can present very sick with multiple organ failure. So the paracetamol overdose is a very kind of heterogeneous group, although it's a single etiology. But the other big cause is so-called seronegative, indeterminate, non-ATE hepatitis, where you don't have an idea of what causes it. That's the second biggest group. And then there's the drug-induced liver injuries is another big group. So that's probably the three biggest causes.
And is there a difference between what we see here in the UK and worldwide?
So paracetamol overdose is it originally was very much a UK problem. It's very common in the US as well. Less so in Europe. If you go over to Spain or Germany, you hardly see paracetamol overdose at all. They have a lot of drug-induced acute liver failure. And then if you go to places like Africa or Asia, then a lot of them will be viruses, like hepatitis A and hepatitis B.
And you've hinted that the presentation can be different by cause, is that right?
Yeah, so the paracetamols tend to run a hyperacute course. The indeterminates and the drug-induced tend to run a subacute course. The complications are different, the clinical course is different, the prognosis is different.
Which has the worst prognosis?
So that's quite a difficult question to answer because it's definitely the subacutes that have the worst prognosis. Okay, so those patients, they're more likely to become encephalopathic, they're more likely to reach transplant criteria, they're more likely to need transplantation. Whereas the paracetamols, they tend to be very sick. But actually, when you're starting to assess them for transplantation, because of the issues that can come with the paracetamol overdose, then once they reach bad prognostic criteria, a significant proportion of them will not be allocated transplantation because of other issues. And then because they're very sick, they tend to survive less well on the transplant waiting list. So when they hit the poor prognostic criteria, the paracetamol overdose patients actually probably do a little bit worse than the subacutes, seronegatives.
Thinking then about the clinical presentation, is it easy to recognise the patient with acute liver failure?
So again, depends on the etiology. Paracetamol overdose, especially when they present as an overdose, are easy to recognise.
Yeah.
The subacutes don't, and there you have to be very wary of chronic liver fatigue, okay? They look very like patients who have got decompensated cirrhosis. The scanning can even show a collapsed liver that looks very like a cirrhotic liver. So you've got to have a high index of suspicion. So kind of short histories in patients who have otherwise been well. You've got to think about, is this a patient with acute liver failure? Because identifying them as such changes the management of them completely.
What about the differentiation between acute and chronic liver failure?
So acute on chronic liver failure tends to happen in patients with cirrhosis. So these patients tend to have the history of cirrhosis before they get to you. So anybody who hasn't got that history, you want to be thinking, is this acute liver failure and not decompensated chronic liver disease or acute on chronic liver failure?
So what are the important things that we should look for or ask about in the initial assessment?
Okay, so the subacutes will potentially have ascites. As I say, the scanning will make them look as if they've got chronic liver disease. And so it's the short history that should alert you to that. High index of suspicion and a very low threshold for progressing to liver biopsy if you can.
Is there anything specific that you would want us to be asking at that first consultation?
So when you're assessing somebody with a severe acute liver injury, the sort of things you're wanting to know is, has the patient got a past history of chronic liver disease? Have they got comorbidities that might influence a decision about transplantation, medical or psychiatric? What's the likely etiology of the acute liver failure? These are the sort of things you're looking for. So basic review of the history and examination and the regular investigations that you would do with anybody with liver disease specifically, and then imaging as well.
And what sort of investigations should we do?
So you want to be doing just the regular investigations that you would do in anybody with liver disease, the etiological investigations. Specifically for acute liver failure, you're probably thinking more paracetamol. You want to know what the paracetamol level is. Then you maybe want to look at things regarding prognosis. So those particular things that we're interested in is not how high the ALT is, but how long is the prothrombin time, how high is the bilirubin, what's the creatinine in the patient's urine output, what's the lactate, and often what's the ammonia helps us stratify the patients. In the subacutes, those are much more difficult to kind of call as prognosis, but it's the same sort of thing. INR, bilirubin, are they encephalopathic?
So you're getting quite a lot of information from the basic tests?
It's no different. There's not rocket science. I know it kind of maybe appears that they come into a black box that is the transplant unit and then get spat out the other side, and but it's just basic attention to detail.
What about imaging? Is there anything special that we should ask our radiology colleagues to look for?
Yes, the things you're looking for often with an ultrasound, you want to know, are the hepatic arteries patent? Does this patient have Budd-Chiari syndrome? Does the liver look cirrhotic? Is there any other features of cirrhosis? Is there any other evidence of lymphadenopathy is another one to look for, because if the patient's got a big liver and liver failure, then you may be thinking about cancer as a cause. So basic scanning, CT if you want, and as I say, biopsy, which often has to be done by the transjugular route, allows you to measure pressures and do proper venography on the patients.
So could you talk us through then just the initial management of a patient with acute liver failure? Okay,
so basic history and examination and the investigations and imaging. But what you're wanting to do is, especially in the hyperacutes, because they can deteriorate very quickly, we manage them all in an HDU environment, allows much closer monitoring. So you're watching the mental state, GCS. You're monitoring the blood pressure. You're watching the patient's respiratory rates and saturations. You're looking for infection, okay? So pulse and blood pressure and temperature. You're wanting to monitor them metabolically very carefully as well. So you're wanting to be doing the blood tests. We'll do them 4 times a day. We'll do the blood sugars, the BM sticks, every 2 hours. We'll be watching their urine output, so low threshold for catheterization. Make sure they're well resuscitated with fluid. And you want early recourse to hemofiltration, because possibly some evidence that will help them too. And so it's really that kind of attention to detail, regular monitoring, bloods, so on.
One thing that often comes up is the issue of abnormal clotting parameters and an anxiety about central lines or invasive monitoring. Is that something we should be worried about? What's your advice?
So we're kind of relaxed about the prothrombin time, which is often what gives people the major cause for concern. I mean, the prothrombin time is one single way of looking at the clotting of the whole clotting system that's involved in managing a patient's kind of risk of bleeding. So in the paracetamol overdose patients, the clotting will sometimes go way high to over 180 seconds, but we won't automatically correct that even if we're putting lines in, because there's this idea of a balanced coagulopathy. Okay, so you look at prothrombin time and it's abnormal, but at the same time the natural anticoagulants are changed. The platelets will be different. So if you look at the platelets, often a very low platelet count, which is common in patients who've taken a paracetamol overdose, that might get down into single figures. That would be more worrying to me about a risk of bleeding than a prothrombin time of 180 seconds. So there's no need to routinely correct the coagulopathy.
So be brave.
No, I think it's just got to accept that PT is one measure of the clotting factor, and it's really clear that these patients have a balanced coagulopathy, and some of them actually may be procoagulant rather than anticoagulated.
You talked about a liver biopsy. What information are you getting from a biopsy?
So what we're looking for there is, does the patient have chronic liver disease, significant fibrosis or cirrhosis? There's patients that get referred to us that actually turn out to have chronic liver disease or alcoholic hepatitis on subsequent investigation. But we'd rather see them and work them up as if they had acute liver failure than miss somebody with acute liver failure. But the biopsy's primarily there to tell us, firstly, does the patient have significant chronic liver disease? Is there any evidence of etiology? For example, autoimmune hepatitis that might respond to steroids. There's some suggestion that the amount of necrosis you see in a biopsy is somehow prognostic. Okay, so more than 70% necrosis is said to portend a bad prognosis, but that's not something that we use routinely in clinical practice. It's really excluding chronic liver disease. Can it tell us the etiology?
And thinking about etiology, are there specific management strategies for the different etiologies?
Yeah, so obviously it depends on the etiology. If you've got a paracetamol overdose, then we always recommend that patients get N-acetylcysteine. We carry on that N-acetylcysteine infusion until the prothrombin time's falling. So that's the most common, if you like, specific antidote. Then seronegative hepatitis doesn't have any specific treatments. Viruses do, okay, so acute hepatitis B, often we'll use antiviral drugs to try and limit hepatitis B viral replication. Patients with Budd-Chiari syndrome with acute fulminant manifestation can sometimes be treated with transjugular shunting. Wilson's disease, if they're not encephalopathic, you try them with penicillamine. The patients who have pregnancy-related acute liver failure, acute fatty liver of pregnancy or HELP syndrome, you want to be having the baby delivered. One of the issues about that is that often means that you've got a very big wound in the uterus, and the coagulopathy, you can often run into very significant problems with bleeding afterwards. So that might be a time when you would be wanting to be very aggressive with your fluid resuscitation and your coagulopathy management.
Are there any common pitfalls in management that you see in retrospect with patients that are referred to you?
I have to say that actually it's not too bad, the management before the patients get to us, but the things to kind of highlight is be aggressive with your resuscitation, because the patients vasodilate just like they're septic. It's very difficult to recognise, are they septic or are they not? If there's any doubt, you treat them with antibiotics. You can use NAC. There's data that suggests that even NAC is useful in patients with non-paracetamol liver failure. So if you've got any doubt, you use NAC. And the other thing is to always think about it, especially in the patients with the short histories. Even though they maybe look like somebody with chronic liver disease, think about acute liver failure, because as I say, it allows them to access transplantation in a completely different way. So the management is very different.
And all of these patients should be managed in an HDU type setting, or is there a role for ITU?
Well, many of our patients go to ITU, so about half of our patients will end up in ITU. Some will start off there being transferred directly in. So oftentimes, if the patient is referred to us and is encephalopathic, we'll ask for the patients to be reviewed by the anaesthetist locally or the ITU staff locally, and perhaps ventilated to protect them on the transfer, because the patient will definitely deteriorate during transfer. And so it's better to ventilate them and move them safely than move somebody and then become encephalopathic, or worse still, fit or develop cerebral edema in the back of an ambulance. And you're talking about sometimes transferring these patients very big distances. So I think HDU environment's better for them. When would you move somebody with a severe liver injury to an HDU environment? You've got folk on the ward who are sitting there with ALTs 3 or 4,000. When would you might move that patient to HDU? Well, certainly when the coagulation is starting to deteriorate, and definitely if they develop any change in their mentation, you'd be wanting to move them to an HDU environment.
Oh, that's helpful advice. When do you want to hear about people?
Well, the easiest way of kind of answering that question is to say, if you're worried about the patient, you're better to phone us rather than not. So we'd rather hear about the patients if you're worried about them than you stay thinking, oh, should I phone the transplant unit or should I not? So what criteria would you maybe kind of worry you? So again, it's not how high the ALT is that's important, okay? So paracetamol overdose, the ALTs can be spectacularly high, 20,000. But that really doesn't matter. It's how well is the liver actually functioning and what's happening to the kidneys. So anybody with a paracetamol overdose who's got a coagulopathy that's advancing, so usually we say criteria for coming to us with a paracetamol overdose is if the PT is higher than the number of hours after the overdose, if it's a single one-off overdose. Certainly anything over 50 seconds we'd want to know about. We definitely want to know about anybody who is encephalopathic. If the kidneys are deteriorating, we'd also want to know about that because they're at higher risk of deteriorating. If you've tried fluid resuscitating them and the lactate's still high, okay, then we would want to know about that too. So that's the paracetamol ones. It's the non-paracetamol subacutes that are very difficult to call. So you could have somebody sitting there with ascites and with a coagulopathy and a bilirubin of 200 or 300, and all they would need to do would be to come encephalopathic, and then they would hit transplant criteria. And that's the sort of person that we would want to know about, because we probably would want to bring them through to look at them before they became encephalopathic. It's always easier to assess a patient, especially for transplantation, when you can actually speak to them.
Yeah. Now, outcomes for patients with acute liver failure have improved, and I think a lot of that is due to the care in specialist settings. What are you doing differently that we're not able to do in the non-specialist setting?
So it's difficult to get an idea of how people do who have got the severe liver failure that we see in a non-transplant setting, because generally they don't get managed outside.
Yeah.
So, it's very difficult to prove that coming to a specialist unit and getting the specialist intervention improves outcomes. That data doesn't exist. I think what it is it's kind of just regular monitoring, close attention to detail, watching the different organs and how they're behaving, and just generally kind of supportive care in an environment that actually is used to managing the patients. And then you've always got the backup of transplantation should things really get bad.
Do you do anything with specialist monitoring or ICP monitoring?
So the ICP monitoring has never been shown to improve patient survival. Really, that's a way of trying to pick up cerebral edema before it becomes too significant. And really, the patients at risk of cerebral edema are usually the young patients who don't have much cerebral atrophy, patients who have paracetamol overdoses, those who are kind of in a sort of SIRS sort of syndrome, so their temperatures are often up, infected possibly. Ammonia levels help you maybe stratify the patients that are going to benefit from cerebral edema. So it's actually one of the biggest discussions we often have with the patients who have got acute liver failure who are ventilated in ITU is, do we put a intracranial bolt in to monitor their ICP? And the risks of that are considerable. It's a tragedy to put in an intracranial bolt and the patient bleed into their brain and die because of the bleed, especially if you've transplanted them. So nowadays we're doing less of it. There are other potential ways of trying to monitor intracranial pressure, but what we try and do is stratify the patients. So if they've hyperacute and they're young and a paracetamol with a high ammonia level and they're going for transplant, then we'll usually think that the risks of bolting them to measure their ICP outweigh the potential risks. That's because around about the time of reperfusion, you can often get a surge in ICP. Oftentimes when you're trying to get off the ventilator as well, they can get a surge in ICP. So certainly the transplant recipients in that group we would be thinking about bolting, but it's much more of a debate and on a person by person basis with input from the physicians and the anaesthetists often to try and discuss round about whether or not the risks of bolting are outweighed with the benefits.
And what interventions do you have if the ICP is increasing?
So we'll use mannitol. The mannitol only works though if your kidneys are working. And that's another reason for introducing continuous hemofiltration early in the patient. So oftentimes when they end up in ITU, they'll get filtered, not necessarily because they've got specific kidney injury, but because it helps clear the ammonia and so on, and helps the cerebral edema and allows you to give mannitol and then dialyze them more to get more of the fluid off them. So you use mannitol, we can use indomethacin, we cool the patient if they're not cold already. Thiopentone we rarely use now. There's another you kind of want to try and get an idea of, are they fitting, and is it an idea that they're fitting? That may cause a raised intracranial pressure. Sodium is another important thing, so we're always watching the sodium, trying to avoid the sodium falling. So we'll make up the NAC in normal saline if we notice the sodium falling. You can use boluses of sodium as well to try and bring it up. So there's a number of treatments you can give. Some people have used indomethacin as well. We've used it in the past.
I imagine one of the difficult decisions that you face is who to transplant and the timing of transplant. How do you rationalise that?
Yeah, so there's well accepted transplant criteria in the UK. They're really poor prognostic criteria. So the idea is that is predicting people whose chances of surviving spontaneously are less than 10%. They've changed recently. They're split between paracetamol and non-paracetamol. So in paracetamol, it's a persistent acidosis despite resuscitation, so low pH, less than 7.25. It's 3 criteria, so grade 3 or 4 hepatic encephalopathy, PT of over 100 seconds, and a creatinine of over 300. Then the lactate criteria were recently modified, so an admission lactate of 5, 24 hours later after resuscitation. Another one that's more than 4 would be the lactate criteria. And then there's criteria that allows you to take the 2 of the 3, the encephalopathy, the PT, and the creatinine. Any 2 of those 3 in a patient that's deteriorating allows you to list them. So that's the paracetamol ones. You can list encephalopathic Wilson's and Budd-Chiari syndrome. And then the non-paracetamol are split into favourable and unfavourable etiologies. In the non-favourable etiologies, we're actually allowing people to be listed who are not encephalopathic, who have got 2 out of the 5 poor prognostic criteria.
And what practical differences are there if people with acute liver failure are listed compared with chronic liver disease?
Yeah, so if you've got acute liver failure, you access what's called the super urgent list. So that's a kind of centrally held national list. That means the patients will get liver offers, or the first liver that comes up in the UK or Ireland. So in general, you're going to get an offer within 2 days because they've got such short prognosis or chances of survival. So that doesn't happen in the patients with chronic liver disease. They can't access that type of list. So the kind of access to transplantation is much more rapid for the fulminants than it is for the patients with chronic liver disease.
And if patients do get transplanted, what's the prognosis?
So probably also depends on the etiology. But in general, you're talking about if you get transplanted, the chances of you getting discharged alive from hospital with your transplant is about 80%. And then about 5 years into the kind of follow-up, you're probably still talking about a survival of between 60 and 75%. And then the longer term survival, because actually many of these patients are young and relatively fit people, then their survival is better than, say, people transplanted for liver cancer, and some cases of patients with chronic liver disease.
And what sort of prognosis do you see if they don't get transplanted?
So it depends on how bad you are. Okay, so if you come with a very severe liver injury, never become encephalopathic, then you've got a 95% chance of surviving or higher. If you become encephalopathic, then that falls. Okay, so it depends on how encephalopathic you are and whether you hit poor prognostic criteria. Okay, so overall, the encephalopathic patients are probably surviving about 40 to 50%. If you reach King's criteria, then as I say, you're talking about a spontaneous survival of about 1 in 10. But nowadays, that's probably a bit better, maybe a bit better in the paracetamols versus the non-paracetamols. So there's maybe up to 20-25% of the people hitting King's criteria might survive if they've got paracetamol etiology nowadays.
And what sort of follow-up do you have for people who survive and are transplanted?
So they slot into exactly the same follow-up as the chronic liver disease patients, so they're wedded to us for the rest of their lives. The non-transplant patients, though, are discharged back to the referring hospital and probably discharged from there with no follow-up whatsoever. So we don't know what happens to them.
So that's a lot of important messages. Are there any messages that you would leave us with?
I've probably forgotten a whole load of stuff that was important to say, but the EASL guidelines have just been published, so that's a good coverage of all these issues around about acute liver failure, and the ASLD have their own practice guidelines as well, so that's certainly worth having a read at. We're a kind of friendly crew. We're only too happy to discuss patients. People shouldn't feel that they can't phone us up. If they've got somebody with a patient with acute liver failure that they're worried about, they should speak to us about it.
Fantastic, thank you. So
You're
thank
welcome.
you for a fantastic update on a really important condition.
You're welcome.
And thank you for joining us for Digest This.